The HAI and infection control team are going to provide you some of our insights through living through a pandemic, challenges and lessons learned. I'm going to do hopefully a shortish introduction, and then Dr. Susan Jain is going to take over and provide some input for the rest of the session. So just to let you know that the session is being recorded, and if I can just remind people to mute their microphones where they're not speaking, and if you do have questions, you can populate that in the chat line. So hopefully you can see my screen. So before we do begin, I would just like to acknowledge the traditional owners of the land where we meet today, and aware that we may be meeting on many lands, and we pay respects to their elders past, present and emerging, and it is upon their lands that we meet. And also welcome any Aboriginal and Torres Strait Island participants to today's session. So I think today we're just going to start with setting the scene for the Clinical Excellence Commission and the Healthcare Associated Infection Program, and then move through how COVID-19 has affected that. So the Clinical Excellence Commission is one of 5 pillars of the New South Wales health system, and the responsibility of pillar agencies is to provide specialist services and support to frontline health teams in hospitals and care settings. The role specifically of the CEC is to lead, support and promote improved safety and quality in clinical care across the health system through consultation and collaboration with clinicians, health consumers, other pillars and the New South Wales Ministry of Health. And there's just a diagram really on showing how we all fit in and how we connect with those. And then if we drill down to a very complex organisational chart for the CEC, specifically in the circle is the usual business as usual HAI team of a small team responsible for healthcare acquired infection, patient safety and infection prevention and control. So business as usual, we focused mainly on a program of healthcare acquired infection prevention, providing resources and tools for the system and supporting infection prevention and control. And whilst infection control underpinned our program, it was probably evident that there wasn't a huge focus or transparency around infection control specifically as part of the program. And intuitively, the team started to make some of those changes probably about 6 months before COVID-19 hit. So recognising that infection prevention and control is a large part of the healthcare acquired infection reduction, and moving the program into recognising and acknowledging some of the work that's specific to infection prevention and control. So did a little bit of rebadging, looked at our website and then tried to underpin some of the infection control requirements with the HAI requirements. Interestingly then, COVID is hit. So, this is the business as usual team up in the left-hand corner. So we have a medical infectious diseases clinical advisor, infection prevention and control officers, project officers with clinical experience. And normally we would be sitting in an office in the McKell building, which very quickly became working from home. And then whilst we have moved to One Reserve Road, it also looks very much like a ghost town at the moment, and many of us still working at home. In response to COVID-19 very quickly, and we'll have a look at the time frames, but we had to increase the support, particularly around the HAI team, given that infection control responsibility in the New South Wales State Pandemic Plan fell solely on the shoulders of the Clinical Excellence Commission. And it's interesting just to note, so, whilst January 20, we had confirmed human-to-human transmission, it was around that date that I let one of our senior lead clinicians on holidays And it was probably 2 days after that that we had the first New South Wales teleconference around the state of an emerging infection and what that sort of looked like. So the early months, January, February, we had very minimal resources at the CC, specifically around infection control, but had a very robust rallying of the entire CC to support the work of the HAI team. And this really just shows you that the CC had to very quickly realign their response around COVID and what the various programs and how that support could continue with the work that was coming very fast for the HAI team. And I think just to give you some, I guess, assessment around what it looked like. So, we have a number of different programs at the CC, and, if we look at the average time people spent on COVID, bearing in mind that they had other work and priorities based on their own programs, that we had elicited a large support bodies around COVID response. And, some people spent anywhere from sort of 0% up to 70%. And I think just to give an indication of, the HAI and infection prevention and control team and the hours sort of spent around that, we were looking at anywhere from, 120% hours worked on COVID up to 184%. And, that sort of equals around about an additional 1,000 hours from, a very small team. So I think it's really safe to say that COVID-19 for all of us has really meant an extreme increase to workloads and an extreme increase to responsibilities, I think personally and also at an organisational level. Very quickly though, we did respond to, putting together resources, and some of our key achievements around, the PPE support. We have around 70 new resources available on our website. We're helping governance and assurance and procurement around product assessment, given that many of our products are new to the system. They may not be our usual sources, and so there's a need to really interrogate what's coming in, and there's an extremely robust system around that again engages a number of other programs within the CC. There's a 24/7 PPE advice line that's again also collaboration with HealthShare. We've had to look at how we do collaborate and increase the diversity of collaboration with the CC. And I think for those of us that are ICPs, infection control practitioners, we're well used to directing our resources at that level, whereas what we've learnt, particularly for COVID-19, is that many clinicians are now looking at our resources and not just infection control. And so therefore there's a real need to look at the way we develop things and release things, and the way that we actually write up things as well. I think safe to say we've had a number of, infection prevention and control expertise site visits, so to some of our aged care facilities, some of the hospitals, just to help with some of the education. We're also moving across other non-government organisations to implement infection control. So our normal jurisdiction would be New South Wales public health facilities, whereas we are providing infection control support for so many other entities outside of health. And I think it's just important to understand that whilst all of us within the CC are doing this additional work, we still have business as usual. So for healthcare acquired infection, we've recently released the clinical indicator manual revision and trying to implement that. There's some changes both at a state and a national perspective around that, and the expectations for the system to complete. We're still obviously trying to support the National Hand Hygiene Initiative. We still have reports of patient acquisitions of multiple resistant organisms, and making sure that our patients are safe, within the system with our business as usual, and then having the COVID-19 responsibilities on top of that. And I think just to go through, and I'm sure that many of us could, look at some of these demands on our system, and we've tried to respond very quickly and have had some great support with that, with other key experts in the CC around, putting a lot of this together. So resources on information, whilst we had a very good platform to start with the policy directive for infection control, a clinical handbook, environmental cleaning policy directive, what was clear was the system was probably lacking on an in-depth understanding of how to pull all those together to then apply intuitively for COVID-19. So we did that work in the background, so pulled what was relevant and tried to very quickly pull together advice and resources specifically for COVID. So for example, we had systems in place for contact precautions, standard precautions, droplet precautions, and airborne precautions individually. But very quickly, given the mode of spread for COVID, we pulled together combined precautions, videos to help the system. And I think it just, this slide here really supports the magnitude of need for some of these resources. So we have close to 70 resources now. We have, over 200,000 downloads, 970 web page views around particularly the COVID-19. And I think too the other safety programs particularly are getting, increased traction around some of this. I think a good lesson for us is really around promoting what the CDC does and what the CDC can do to support the system more globally, I guess, around that. I think though, and Susan will probably touch on this a little bit later, there's still a massive need to ensure patient safety is at the core of many of, if not all of our resources. There has been a little bit of a shift, and whilst it's important to understand that, workplace safety is very important, ensuring confidence in the system, we still can't ignore the patient safety perspective. And I think sometimes with COVID-19, there's a little bit of work still to happen to make sure that patient safety continues as a priority and key in our response. Just, again, to look at, our emails and why many of you will probably receive emails from some of us, particularly me, very late at night is, between, the period of January to September, I've had 45,000 emails in for the same period of time. Last year I got about 18,000 emails. It's good to know that not all of them, need a response. We can actually redirect some of them, but at least our response has at least doubled. And we've also increased our email boxes. So we have our personal email boxes, we have the HAI, like community box, and then we also have the COVID-19 inbox, the IPAC COP inbox, and the ID COP inbox to try and separate the workflow from each of those. So if we look at the COVID inbox specifically as well, that's 17,056 emails, many of which require quite a large body of responses. Some of that is people providing us with information, but many are requiring responses as well. And I guess for those of you that may not understand the government system, on top of our sort of clinical work, we then need to respond to a number of ministerials and provide information to government around the response and request for information and that as well. One of our colleagues in the CC also helped with implementing some work around interrogating emails and was able to bring together word clouds. And they're some of the key sort of themes. So in terms of frequency, it was, a lot around PPE, health, mask, the patient is still there, but probably not where, from a patient safety perspective, we would normally like to see them. And then in terms of ranking, again, I think it's, guidance, mask use, cleaning, patient are all sort of relatively consistent with that. I think really just this very simplistic, it certainly does not compete with my colleagues in the CC. I think for the first time I learnt very quickly what a swim lane looks like, and I'm certainly not at that level, but I guess looking at what we had in place historically, and that's, we did have a robust governance system that has served us very well, but we are understanding very quickly that there needs to be some changes in some of that governance. We have jumped on board with, the community practice, so the infection prevention and control community practice, but also the infectious diseases. But if you look on the left-hand side, it's how we actually progress this governance to further meet what we need for COVID-19. So there's some work currently around that. And I think too, because we do have clinician engagement from a diverse range of clinicians, looking at how we incorporate that expertise and that desire to contribute into a broader multidisciplinary expert task force that obviously has infection control, infectious diseases as lead, but also has consideration for those other disciplines. I think this is just really to really understand that there is a lot of information there. We now as a program, provide expertise in infection prevention and control and assist local health districts and special networks in New South Wales to manage and monitor the prevention and control of HAIs. And we do try to listen to the needs of the system and get things out relatively quickly, but as you can appreciate, it is sometimes difficult to write things from a statewide perspective, and that will meet everybody's needs. And so we try to write around principles that then LHDs and individual facilities can underpin local guidance for. And I think, the one lesson particularly, for me, and Susan will expand on a number of the lessons that we've learned around this, is that, it's the importance of, it's the understanding of and the implementation of infection prevention and control that cannot be underestimated. Many of us have been doing this for over, decades, 20 plus years longer. Our message seems to have been, it has been the same. I think it's nothing like a pandemic to get people interested in infection prevention and control, but it would be nice to continue the momentum beyond a pandemic and get all our clinicians engaged in how important infection prevention and control is for patient safety, but as well as staff safety, wellbeing, and broader community safety. And, I think this is probably me most nights at about 1 a.m. So big lesson learnt for me is to try and switch off, and that's really difficult for us given the demands, but we are surrounded by very good support networks. The infection control community are working extremely hard to support the system and support our team as much as anyone else. And, there's a fabulous team at the CEC, and we cannot also implement and do the work that we do without the strong commitment and dedication and passion from the HAI and infection prevention and control team at the CC. So I'm going to run to my next meeting and hand you over to Susan. And I know that she's got an exciting follow-on from this talk. So thank you all for listening, and any questions I'm sure Susan and the team can answer. So I'm going to hand over, Susan, to you.
Thank you so much for such a great overview of the, excellent work we all do here. I'm going to take you through a few of the lessons learned or challenges in a slightly different perspective. I hope you enjoy the next 15-20 minutes with me. So 2020, my God, what an year. So we learned so many things this year. So just starting off, being alive in 2020 is special because that is the only year you are likely to live through where the first two digits will match the second two digits of the year. The next year that follows this pattern, like 2121, a person alive now would have to be at least 101. I'm not expected to be living that long. So if one of you out there is going to be, then cheers to you. So this year is, it's a mighty year, I would say. So let's begin with what else we have learned this year. 2020, again, we're going to remember, at least our kids will be saying that I have lived through a pandemic, and we have too. So year of a pandemic, COVID-19 represents a global crisis. Um, so I haven't changed these numbers. As you can see, the numbers is wrong. So I put this presentation together for the 16th September, but these numbers change now. So you all know how many cases we had, almost 29 million up until now, and maybe 96 also thousand lives lost. So ignore that number, so it's not the updated number. I apologize for that. So in many countries, high rates of community transmission have resulted in extreme pressure on health services like we had in Australia. Frontline healthcare workers had infections. Luckily, Australia didn't have any lives lost, but I'm sure across the world, I would like to acknowledge the people, the healthcare workers who lost their life or the family members who had impacted because of the COVID, and also impact on global economy. And we're all going to live through and we're going to see the brunt in coming years. On top of that, mental health issues. I'm sure a number of people out there really struggling, including relationship breakdowns. And also, I would like to acknowledge the patient safety aspects we probably may or may not considered this year because it was all about COVID, all about pandemic in my view. So what is a pandemic and what's the difference between a pandemic and an epidemic or endemic and outbreak? I'm sure most of us know, but I thought I'll just touch base on this. An epidemic is a disease that affects a large number of people within a community or a population or a region. And a pandemic is an epidemic that spreads over multiple countries or continents. Endemic is something that belongs to a particular people or a country. An outbreak is a greater than anticipated increase in the number of endemic areas. It can also be a single case in a new area. It's like in a MERS, for example, we would say, yep, it's an outbreak. Or if it is not quickly controlled, an outbreak can become an epidemic. So that's where the definition sits. So among these, we are in a pandemic situation as we speak. Coronavirus, I'm sure you have heard a lot about it, and everyone, let alone 3-year-old kid, probably will understand what is COVID-19 or coronavirus. But just in case, if you haven't looked at the definitions, just to reiterate the fact that coronavirus are a large family of viruses. Some causes illness in humans, and other causes illness in animals such as bats, camels, or civets. Human coronavirus causes mild illnesses such as common cold. A severe acute respiratory syndrome, SARS, is a viral respiratory illness caused by coronavirus called SARS-associated coronavirus, SARS-CoV-2. And previous coronavirus have included SARS-CoV-2 and MERS-CoV-2. So severe acute respiratory syndrome COVID-2 is a new strain of coronavirus that has not been previously identified in human. So that's where we are now. Origin, we probably all debated. I'm sure media and newspaper all debating on where it came from. There are so many myths and theories around it. But at the moment, the most trustable one is the most likely ecological reservoir for coronavirus are bats. But it is believed that the virus jumped the species barrier to human from another intermediate animal host. This intermediate animal host could be a domestic food animal, a wild animal, or a domesticated wild animal which has not yet been identified. So we're still searching for that answer, how it all happened and where it's come from. We don't have an answer for it. So COVID-19, the virus that causes COVID-19 known as SARS-CoV-2, it appears to have first emerged in Wuhan, China in late 2019. The outbreak has since spread across China to other countries around the world, and I don't think any of the countries left now not be touched by this COVID-19. By the end of January, the new coronavirus had been declared a public health emergency of international concern by the WHO, World Health Organization. And that's where our lives changed in Australia. As you can see from the this timeline, 25th of January, the first confirmed case identified in Australia. And from there on, we all know what happened, the history. So I don't need to go through stage by stage of what happened from then. And this is just a snapshot of what happened in New South Wales. We had a number of cases. And at the moment, we are luckily managing it well compared to Victorian colleagues. I would, my thoughts for them. We, collectively as a team, including us, CAC, and everyone out there, played a huge part in bringing that massive graph down and where we are at the moment now. So we hope that this is how it's going to stay. So when talking about controlling an outbreak, the most important part, I think, is hand hygiene, cleaning our hands, because hands can be called as a mass weapon of destruction. It can do anything, can pick up things from one place to another. But this is just the audit report, we have pulled from the, National Hand Hygiene Australia. And you can see 2020, what changed? Yes, our hand hygiene compliance rate gone up. We're sitting at 89%. Compared to the early 2020, which was under 86%. But the numbers submitted to the database was less compared to previous audit periods. But saying that, this shows hand hygiene compliance definitely gone up. So that explains maybe our coronavirus numbers are low too. So trying to be optimistic, and I'm sure if we keep cleaning your hands, we're probably going to not to have more cases. Let's think that. Okay, our challenges, number of challenges we are facing and also we're going to face, I think. So life changed forever, I think. And we learned that COVID spreads primarily from person to person by droplets received or released when someone sick, sneezes or coughs, can land onto the mouth or nose of people or nearby, or basically contaminate someone else's mucous membrane. Also, close contact with someone sick, like hugging or shaking hands. Then we also learned that COVID-19 mainly spread from person to person by or intermediate objects like hand-to-hand transmission, or by touching lift buttons, for example, or laptop or mouses someone else used, or mobile phones, tissues, doorknobs, pens, all these things, anything which inanimate object which can move from one person to another or stale, can harbor this microorganism, and we can go in and pick up on our hands, contaminate our mucous membrane, and then get infected with. So it's a challenge. Definitely, it's a challenge. It's not like other microorganism we have dealt with before, or it also might be slightly different from influenza. So also we learned, this is just a graphics of how the transmission happens. So like if an individual who is infected can shed microorganism, it can be a droplet, which can be more than 5 micron in diameter, travels almost a meter, or it can become small droplet nuclei under 5 micron diameter and can become airborne and go to a susceptible host or individual by airborne transmission, droplet, or by direct contact or indirect contact. And also we learned that currently 4 out of 5 people infected with COVID-19 will experience mild symptoms or moderate symptoms. But some people can have severe symptoms too, like some may ended up in ICU or in a hospital admission for a longer time. And we also learned that there are differences between, the symptoms of COVID, common cold, and also flu. So there are some significant differences which is listed in this slide. I'm not going to go through all of them, but by now we all know that COVID is different from flu, and also it's different from common cold. And then the challenges we faced, the restrictions. I'm sure the word restriction is just lives with us now. Everything is restriction. You can't go close to someone. You can't give a hug to someone. You can't say goodbye or inviting kiss to someone. Visitors can't go to hospital to goodbye to their loved ones if they're unwell or sick, or just to go and see them. You can't even sit with someone. I think Australian, we are not used to keeping such distance from everyone. 1.5 meter become the rule of our life now. Everything goes around 1.5 meter. Because I was just in the office when my colleagues came to me. I had to be mindful that am I breaching that 1.5 meter distance, or are they going to breach the 1.5 meter distance? It's become a part of our life, and I don't know how we will live from now on with this within 1.5 meter rule. So this completely changed our perspective. So if you look at socially, you can't have dinner with number of people, you can't go to someone's place, all these restrictions. And also every day when you turn on the news, you will hear more restrictions. So that's what the challenge, I think, is one of the main challenges we're facing is, the things we are doing is not used to. We are social animals and we like to spend time with people, but this is not letting us to do so. And also we learned public health restrictions. And also we know that if you had contact with someone who probably had symptoms, you need to get tested. So we are surrounded by testing clinics now. Contact tracing, you can get a phone call from public health unit anytime, like you are a contact going to quarantine. And then as Kathy touched based on, we started working from home. I'm sure most of us are having that taste of working from home. This is the concept is very hard to accept for some people because we again love to come to work, see our colleagues, our friends, have a chit chat, just asking that, are you okay? It's not just a one day question. It's about, living with it is the challenge. I think we start living with asking, are you okay once in an year? Otherwise, we used to ask everyone every day, like, how are you feeling today? How was your night? Or did you had a good day or not? That changed. And if you have to go to a GP, you pick up the phone and ask for a teleconsultation rather than turning into the GP's practice. If your family members in an aged care sector, the difficulties you have to go through to get a visitation, and we are protecting them. I'm not challenging all these restrictions are not good. Yes, they are. We need them. But unfortunately, 2020 taught us all these restrictions, I think mainly. Protecting vulnerable population, yes, again, that's our responsibility. That's why we put restrictions in place. We have to reconsider hospital visit. I haven't had my dental check this year, just in case you are interested in knowing that, because worried that when this COVID is in the peak, I don't want to go to a dental practice. Using remote technology, I became the tech. Learned a lot by using Teams to Skype for business to Zoom. I don't know how many new technologies we're using now. And also restrictions on gatherings. You need to think who you can invite to your family or if you can go to someone else's place. And then focus on infection control in hotel quarantine. Like, if in case you have to travel, you come back to Australia, if you go to a different country, you will be locked up for 14 days, which we never thought of before. Commercial business being affected, health accommodations and hotels we are dealing with. There are a lot of airport operations happening. Music instruments, those people asking us, how should we clean? I don't think any music instruments cleaned ever before. So the good thing probably is that we learned to clean and we learned to keep distance. Sporting, schools, residential aged care facilities. I think everyone's life touched and changed this year. I don't think anyone in this earth will say that they haven't heard of COVID-19 or it has had impact on them. The challenges faced by healthcare facilities, people like you out there. Management of suspected and confirmed patients with COVID-19. what to do with them. And also I was wondering what happened to all the other problems, VRE, MRSA, CPE. We're not worried about them anymore. We're not hearing about them. I don't know if at the hospital side you are, but certainly in CEC, our whole focus fully 24/7 is on COVID. Hospital preparedness, such a challenge. You need to accommodate every other patient's safety aspect, not just COVID, but balancing is the challenge. Adapting to a new microorganism, a lot of questions, still we learning, still the research coming out. Every day you learning something new about COVID. A lot of information's out there. We don't know which one to look and which one to trust. Should we go with CDC, which US recommending us to do, or should we listen to World Health Organization, or should we listen to any other country? Developing biosafety, managing laboratory examinations, point of care test. Should we use saliva test or should we use deep throat and nasal? Still debate out there. Anticipating in the increase of cases, anytime we are waiting that to happen, another peak, another cluster. Like we don't want to be like Victoria, but you never know what will happen. That anticipation is always there. Logistical considerations like moving patients in a hospital or a radiology examination or before a surgery, everything changed. It's all challenges we're facing every day. And we know that it's not that easy. It's not easy to live through all these each and every day for almost 9 months or 10 months now. More to come, links with pre-hospital care. If you have HIT or any other hospital programs, that's all been affected. Managing and taking care of healthcare workers, the impact on us, our anxiety every day when you wake up and get ready to go to work, you probably don't know that you will bring some COVID with you or not. Increased need for healthcare workers. Yeah, there's a lot of shortage, a lot of demand, and maybe you all overworked out there. As Kathy said, excessive hours, no time for sleep, no time for taking rest, no time for taking leave. Continuing usual care, research, teaching activities, it's all been impacted. Increase in the availability of beds. Do we have enough bed ever? And are we going to have many beds available? No, we're not going to have any of that, but we have to live and learn how to use what we have. So this slide actually showing the proportion of environmental samples suspected positive by items in London. So this is the slide which shows that when they did a test on these inanimate objects like computer keyboards, hand hygiene dispensers like gel dispensers, chairs, toilet seats, and you can just read. So the blue box is the suspect COVID-19. And the positive one is the confirmed COVID-19, and the white part is the negative. So as we can see, always the case, we always think that toilet door is the most dirtiest one, but we can see that the toilet door actually culture the most negative, COVID-19 there. So are we saying that we all, cleaning hands and coming out with the clean hands and touching the toilet door? I'm not sure is this inside the toilet or outside the toilet, which wasn't clear from the study. But I thought it's an interesting item which we are learning, still learning. So new way of life, our life changed. Physical distancing become our life. Hand hygiene, can't say enough. Cough etiquette, we know how to do cough etiquette, but I'm sure that's something being looked at very closely and clearly this time around. Surgical mask, face touching, and we learned, and maybe some studies done previous years that in a normal day someone will touch their face 21 times in an hour, but with COVID I don't know if that number increased or decreased, but we always recommend people to keep their hands off face. Surgical mask is our best friend. We can't live without them, and you will see a lot of mask use out there. But we need to know how to put one on, how to handle them. I was sitting the train this morning and I saw someone had mask inside out. I really wanted to tell that person to use the way it should be used, because the outer layer is the one which has the fluid repellence, not the inner layer. So if you use it inside out, you're defeating the purpose. But I could not say to that person, they had earphone and was very busy with their phone, didn't want to intervene. But if you get the opportunity to correct please tell people how to use the mask properly. Otherwise, it's no point using one. So I thought I'd just put this slide in here to, if in case someone out there don't know how to put a mask on, there are so many beautiful videos out there you can go and watch, but always clean your hands with soap and water or hand sanitizer before touching your mask. Remove the mask from the box and make sure that there are no obvious stains or break, because there are a lot of new products being flooded into the market or the system. So you need to be very careful with the item you're picking up and checking them it's perfect or not. Determine which side of the mask is the top. It's important, as I said, that people can use it inside out, upside down, like either way. But make sure that you get your top and bottom right, and also inside out. Which side is the mask is the front? The colored side of the mask is usually the front and should face away from you, while the white side touches your face. Normally, that's the color combination you see. Mold or pinch the a stiff edge to the shape of your nose. If using a face mask with ties, then you take the bottom ties and then you tie and also the top ones. Or if it is loops, you hold the both loops and put them on, and pull the bottom of the mask over the mouth and the chin to get that cover. So it's really important that when you pick up a mask, check the front and the back, and also the top and the bottom. This is not just for the healthcare workers. Anyone who is using a mask, it's important to do all these steps before you don one. And then mask etiquette, a new terminology. I just made it that you need to understand the mask should sit to cover your nose, not under the nose, and also your mouth and on your chin. So there are a lot of strange, interesting ways you probably may see when you go to supermarkets or train, the way people use masks. But there is a specific way you tie them, you use them, and it should stay on your face. You should not remove it and put them back into your bag or your pocket, or just crunch in your hands and then walk around. So it's really important that we learn how to use mask, and I think our life will be from now on, or in this year, based on mask use, because it's not going to go away anytime soon, and we're going to see more and more masks being utilized. It's not all about the mask though, because some people, and especially in healthcare, I think everyone fighting for respirator or mask. Why can't we use mask? It's not all about it. It's all about using the physical distancing, or making sure that you are physical distancing, you're cleaning your hands, and also looking after each other. Like PPE comes last when it comes to the hierarchy of control. We need to look after each other. Sometimes, as in this picture, you can be left alone. You will be just, in your shadows. You don't, especially in this patient safety day we're talking about, we need to look after each one of us, because one of us can be a patient in any minute or any time. So the way you're going to look at it is all just not about wearing a thing on your face that will protect you forever. It's all about having a bundle approach, not just one item. Also, we learned that yes, cleaning hands is the best. Coughing onto your sleeves, and also avoid touching your face and nose. I don't know how many times I should repeat that, because please keep your hands off your face. Limit social gatherings. Avoid close contact with sick people, and if you know someone is sick, encourage them to go and get tested. And more importantly, cleaning of the surfaces. And I'm glad that the culture of cleaning just merged into us again. But this morning again, when I was sitting on the train, I saw one guy who came in to clean, was using one wipe and started from one carriage to next to the next. So just wiping is not going to be enough. We need to understand why are we doing the cleaning? What are we cleaning? And what is the effect of that cleaning? Are we spreading everything from one place to another, or are we picking up and removing it? So it's important to do appropriate or proper cleaning. So make sure that we do it with fresh clothes, change the clothes in between, or if you need to use the proper chemical, if the disinfection is involved, we need to make sure that the contact time is being looked at, check the manufacturer's instructions. There are a number of things we need to learn, and we're still learning. And also, our new norm or new normal is to stay away from people. keep the distance, then if you can keep the distance, sometimes you can not to have a mask on, because by putting one mask on is not going to be enough all the time. So that's again, it's going to be the norm for us, keeping distance and having mask. A few questions just came to my mind. I'm sure, you probably may have heard this too, like, is hand sanitizer effective against COVID-19? Yes, it is, I would say. Should I be using antimicrobial soap to wash my hands? No, you don't have to, because you're not trying to kill anything on your hands by washing. You actually want to wash it off by using friction and the movement of running water. Where can I buy hand sanitizer? If I can't find one in store, can I make one? No, you can't make your own one. There are specifications around how to make hand hygiene product. And also you don't want to make something in your backyard and then use it, so that may kill your skin. You don't want to wreck your skin. So there is no backyard hand sanitizing production we expect. But you can always buy that from supermarkets or anywhere if you want to use outside of the hospital. But hospital definitely will provide you when you are within the facility. Is the Ministry of Health taking measures to increase supply of hand sanitizers? Yes, it's an ongoing work, and as HealthShare always on top of things, and they know how much they need, and it's always the case that's been looked at and is being considered. What do I do if I get a rash or other reactions to my hand sanitizer? I think if you stop using it as soon as possible, if it is outside of your health facility, see your GP or talk to your practitioner. If that inside your hospital, speak to your infection prevention and control, report, notify. If it's your work health and safety people is close by, speak to someone. I'll probably say infection prevention and control is the best to go to in situations where you develop a rash. If it is on your hands, and also if it is because of the use of the mask, like pressure injury or allergic reaction from any product you use in hospital, you should go through your normal reporting channel and also speak to your infection control. The challenges, again, we missed a lot this year. As you can see, so many things. I'm sure you probably can equate to most of this listed in here. But yeah, we have missed a lot, and we hope that things will come back to us. We learned to protect us from COVID. I'm sure we have done a fabulous job so far by protecting us. Maybe a few people didn't, maybe around 3,000 of them picked up, but the rest of our 5 million people in New South Wales, most of us managed to protect ourselves. So you are doing a great job, I would say. Things we learned from cleaning hands to cough etiquette to disposing tissues properly, using masks properly, keeping the distance, cleaning, and staying home when you're sick. We learned all this, and we have protected ourselves, and we have protected other people. Also, we learned that this is an evolving phenomenon and new information coming up every day. And we need to reinforce the PPE, donning, doffing. We think that healthcare workers used to using it, but hey, you need to have buddy, you need to have tiger teams, you need to have champions going around and reminding people the proper way to don, doff, appropriate use, or while you're using it, the etiquette, what you need to maintain, proper disposal, and you should take time to doff, clean your hands in between. You need to have a proper doffing space. Again, hands off from your face. In my slide, there is a typo. I have A's there, but please read that as a face. I missed the F there. Supervision, buddy system, do auditing. You need to have a PP champions, etc. Contact reminder, like physical distancing. Sometimes you may need to remind people to, please keep the safe distance. And sometimes consider the patient behavior. So if they are delirious, confused, if they are in a high risk behavior, you need to do the risk assessment there and then choose the appropriate PPE, or the management should be based on the risk assessment. And if you're going to have a care provision for a length of time, if you're going to have care provision in a close proximity, or if you have a number of cases in one place, your strategy probably will change when it comes to your PPE utilization. Also, we learned manage crowded workstations. Tea room interactions can be a challenge sometimes or can cause transmission. Make sure that you do it safely. We have just released a document on safely using shared spaces. Go and have a look at that document if you haven't seen one. Consider the interactions you have, like a coffee run or just walking together, traveling together when you're off work. All those kind of interactions can have some impact. Hand hygiene, as I said, cannot say enough. Again and again, it's the really most important part. Cleaning, cleaning, and cleaning. Make sure you clean it properly, not just because you have a wipe and you go around from one room to the next. You need to do it properly. Wipe the high-touch surfaces and also share items. And more importantly, communication. You need to keep an eye on social media, internal channels, and virtual info, but making sure that you pick up the right information from the right source. Not everything comes out from the media or the internal channels or the other social media is right. So to sum up, the coronavirus pandemic is causing large-scale loss of life and severe human suffering globally. It is a public health crisis without precedent in living memory, which is testing our collective capacity to respond. The most urgent priority is to minimize the loss of life and health. But the pandemic has also set in motion a major economic crisis that will burden our societies for years to come. Now is the time for urgent and large-scale responses to be taken at subnational, national, and international level, and we are in it together. So to sum up my slide, I just want to leave this slide for you as your reflection for today, and hope you enjoyed listening to me.